Hello, everyone, and thank you for joining us for an ICA webinar. My name is Georgia Matheos, and it is my pleasure to be your host from ICA for today's webinar. We also want to thank Abbott Nutrition for sponsoring today in partnership with Defeat Malnutrition Today, and they have brought together a wonderful panel and a very unique topic for us to learn from: food as medicine, nourishing Native American elders for holistic health. In a moment, I'll be turning it over to our moderator, Heidi Robertson, as she'll take over for the presentation. Today's webinar is being recorded and it will be live on that recording for about 7 days. So I'll send that out to your inboxes tomorrow, where you can watch it again or share it, and you can send it to anybody that you like. If they couldn't attend or if you thought somebody might enjoy it, it's live for 7 days. After that 7 days, we do put it onto the ICA website, and it's active for our ICA 100 members and our organizational members. And that's part of a library of webinars that we have on there dating back several years. So you'll always have access to that. Throughout the webinar, if you have any questions, you can type them into the chat box and we'll get to them at the end. So we'll have the two speakers, and then at the end, we'll do all of the questions. So at this time, I'd like to welcome our moderator, Heidi Robertson.
Thank you, Georgia, for that introduction. So I'm Heidi Robertson. I work with the Older Americans Act Title VI programs as the nutrition consultant. So I am able to provide a lot of training, technical assistance, and support to the Title VI programs, which are for American Indians, Alaska Native, Native Hawaiians. And I have the great pleasure of introducing our speakers today. So we'll start with Dr. Collette Adamsen. So Dr. Adamsen serves as an Associate Director for the Center of Rural Health at the University of North Dakota School of Medicine and Health Sciences, and is Assistant Professor at the school. Collette is also the Director of the National Resource Center on Native American Aging, which in this position, Collette provides grant project direction and leadership, conducts research on health disparities among American Indian, Alaska Native, Native Hawaiian elders throughout the nation, manages data for the Resource Center, and functions as an American Indian content specialist. Previously, Collette served as an project coordinator beginning in May 2014. Prior to joining the Center for Rural Health, Collette worked as a redetermination examiner and redetermination officer at Nourishing Healthcare Solutions. Collette received a Bachelor of Arts degree in economics, a Master of Public Administration with an emphasis in health administration, and a doctorate in educational foundations and research from UND. Collette is originally from Belcourt, North Dakota, and is an enrolled member of the Turtle Mountain Band of Chippewa Indians. All right, Collette, I'll let you take it from here.
Thanks so much, Heidi. Thanks so much, everybody, for joining us today, this afternoon or morning, wherever you are. Today, we are going to talk about food as medicine. And so I'm going to look at food sovereignty and the role of traditional foods and Native elder health. As we know, diet and food play an important role in our health overall. And having access to healthy, nutritious foods is very important for us to have an overall good health and well-being. And looking at the history of our population, sorry, next slide. Looking at the history of our population, due to a lot of historical traumas that occurred with our population, we found that our health overall has declined, and our people are experiencing higher health disparities than most groups do across the nation. And so a lot of this happened because of colonization, our loss of land, loss of our language, our access to our traditional foods, being put on reservations, boarding school traumas. All of this played a role in the decline of our health and being introduced to different diseases that our population wasn't used to being exposed to. And so during pre-colonization, before colonization and assimilation, our people were essentially free of chronic conditions and infectious diseases because our diets consisted of crop-based foods such as maize, beans, and squash, and then lean meats and seafood such as bison, deer, fish, salmon, just a much healthier diet. So once our people were exposed to a westernized diet, it was very detrimental to our health. Our people weren't used to this westernized diet, which consisted of high fat, high in sugar, low in grains, lacking fruits, low in fiber. It was just a very unhealthy diet. And I was talking to my auntie a few years ago. She's a family physician. Actually, she's retired now, but she used to tell me that even today, our bodies are like in our communities, we're not able to process this type of food. So it's just really been detrimental to our health. So we experience a lot of the higher health disparities compared to other populations, as I mentioned. Next slide. And so whenever we look at our traditional foods and our culture, it's a sign of our strength and resilience. It serves as a protective factor for us, especially our traditional foods and helping to manage good health and wellness. And it'll serve as a primary vehicle for delivering healing to some of the results of this poor diet that we were exposed through colonization and assimilation, and just help us recover from some of those historical traumas that have happened to our people. Next slide, please. So when we look at our medicine wheel, it's believed that for the 4 realms of mental, spiritual, emotional, and physical health, if any one of these is out of balance, then we're not healthy. And this is at the root of our health disparities, is whenever we don't have balance in these areas. So when we had the loss of our land, of our traditions, of our traditional foods, of our language, that all had an impact on our people. And so we were out of balance with these realms. And the purpose of looking at food sovereignty and bringing back our traditional foods and our culture is to bring all of these realms back in balance, because once we can get those back in balance, then we're going to have a much improved health and well-being for our people and our elders. Next slide, please. So when we look at our traditional foods and culture, we look at it as medicine because it's a part of who we are. And it's believed that if any of that is oppressed our culture, which includes our traditional foods, healing's required to restore that connection. So connecting back to the land, connecting back to our culture through our medicine, our ceremonies and community and health, that's going to serve as a protective factor and promote our resiliency and help us recover from this historical trauma that impacted our people and impacted our health overall. Next slide, please. So looking at the definition of what food sovereignty is, so the First Nations Development Institute defines it as the right of American Indians, Alaska Natives, and Native Hawaiians to produce their own traditional foods on their own lands to sustain themselves, their families, and their communities. Native Americans had food sovereignty for thousands of years before the first European contact in the Americas. Food systems have been dramatically changed to the detriment of our Native people's health. Next slide, please. Another definition is food sovereignty goes well beyond ensuring that people have enough food to meet their physical needs. It asserts that people must reclaim their power in the food system by rebuilding the relationships between people and the land and between food providers and those who eat. It's rooted in the ongoing global struggles over control of food, land, water, and livelihoods. So essentially, our people are looking to be able to bring back our control of how our food's produced, having access to our traditional foods in our tribal communities, having access to that healthier food in our tribal communities, with our traditional foods, because in our communities, a lot of times we don't have large supermarkets that have, fresh fruits and vegetables. A lot of times, especially our tribal communities that are for the most part in rural and isolated areas, we don't have access to those healthy foods. Sometimes we have to drive an hour away, a couple hours away, just to access some of those larger supermarkets. So bringing food sovereignty into our community will allow us to be able to produce our own foods, control that distribution, control that production of food, and to focus on our foods that are part of our culture and our traditional foods. And that'll be the key to bringing back and balancing those 4 realms in our medicine wheel, to improve our health and well-being overall. Because food is truly considered medicine for our people, our traditional foods. Next slide, please. So now I wanted to share with you some data that we collected. We conduct a national survey with our tribal Title VI program. So Title VI is our nutrition, caregiving, and support service programs that are funded specifically for our tribal elders and tribal communities for those areas. And so every 3 years we conduct a survey with those communities. We work in partnership with them to conduct this needs assessment. And so this last cycle 8 that we conducted wrapped up March 31st of this year. So looking at our participation, we had 19,744 Native elders who are 55 years and older. And of those 19,744 Native elders, we looked at those that did not have access to traditional foods or didn't consume traditional foods regularly. And we see that we had 11,077 elders who had reported those circumstances. And then we had 6,376 Native elders who reported having access to traditional foods and consuming them regularly. So looking at those who consume traditional foods 1 to 2 times per week, we had 57.1%. 26.4% had consumed traditional foods 3 to 4 times per week, and then 16.5% consumed traditional foods 5 or more times per week. Next slide. So for this next slide, what we did was we had asked the elder what types of traditional foods they had consumed. And so that one was open-ended, so they could write down any response or as many traditional foods as they could identify that they had consumed. And so the larger words are the ones that were reported most by the elders. So we can see that fish, beans, meat, corn, deer, salmon, berries, and even fry bread were reported as having the highest consumption by our elders for traditional foods. And one interesting story I just want to share really quickly is, so fry bread really isn't considered like a traditional food of ours, pre-colonization, I guess, but post-colonization, we had fry bread. And so I had read this article and it was really interesting how they explained fry bread being a traditional food of ours. As it was more of like a resiliency food. So when we were put on reservations and our people were given rations by the government, this wasn't even really enough to sustain our people with food. But what they did is they took what they had and they created fry bread. So it was considered like a food of resiliency. Like our ancestors took what they had and they created something to survive. And so that's where fry bread came from. So I kind of say that, fry bread power has a whole new meaning to me since I read that article. So, it was really interesting to me. But next slide. Okay, so for this next table, we looked at traditional foods and diabetes, and we broke it down to 4 categories. So you have those who did not eat traditional foods, those who consume 1 to 2 times per week, and then 3 to 4 times per week, and then 5 or more times per week. So I'm going to focus on the ones who did not consume traditional foods, and then the 5 or more times per week. So for percent of diabetes, we had 41.9%. Who reported having diabetes that did not eat traditional foods. And then we look over to the right, that was compared to 32.4% who reported having diabetes where they had eaten 5 or more times per week traditional foods. So eating traditional foods 5 or more times per week served as a positive or a protective factor in having a lower rate of diabetes compared to those who didn't consume traditional foods. Next slide. And now for this one, and I'll go through a couple because I know I kind of got to watch my time here, but so the percent for reporting exercise regularly, we had higher rates of those who consume traditional foods 5 times or more per week. They had higher rates of reporting exercise regularly than those who did not consume traditional foods. So 78.8% compared to 69.8%. Obesity, there was lower reporting of obesity for those who consume traditional foods 5 or more times per week compared to those who did not. So 41.5% to 46.6%. And okay, next slide, please. And then looking at traditional foods and nutrition. So when we look at those who consume traditional foods 5 or more times per week, 18% compared to 24.6% had reported an illness or condition that changed the kind or amount of food they had eaten. And then we see that those who reported eating fewer than 2 meals per day, 11.2% had consumed traditional foods 5 or more times per week compared to 17.8% that did not eat traditional foods. Next slide. For this one, we looked at nutrition. So if they had a good nutrition category, moderate risk for nutrition, or severe risk for nutrition. When we look at the good nutrition category, we see that those who consumed traditional foods 5 or more times per week had a better good nutrition at 56.6% compared to those that did not eat traditional foods at 49.2%. And then whenever we look at moderate risk to severe risk, we see that those who consume traditional foods 5 or more times per week had less of a risk of being moderate to severe nutritional risk that compared to those that did not eat traditional foods. Next slide, please. So affordability, so food security and traditional foods. So food that did not last and there was not money to get more in the last 12 months. So those elders who reported often are sometimes true. 33.5% did not eat traditional foods, and then 28% were under the category of eating traditional foods 5 or more times per week, could not afford to eat balanced meals in the last 12 months, often or sometimes true. So we had a higher rate at 37.4% for those that did not eat traditional foods compared to those that did 5 or more times per week at 27.8%. Next slide, please. Just again, more food security and affordability questions. So cut size of meal or skip meals because not enough money for food in the past year. We see again that those who consume traditional foods had experienced this less often at 13.4% compared to those that did not eat traditional foods at 16.1%. And then you can kind of see the results there for affordability. Those who consume traditional foods 5 or more times per week seem to experience some of these areas of food insecurity less than those that did not eat traditional foods. Next slide, please. Cultural participation. So as we look at this table, we can see the elders who consume traditional foods 5 or more times per week. They reported higher participation for cultural practices at all the time compared to those that did not eat traditional foods. And then if they had any involvement with cultural practices, they tended to have a higher percentage of elders who ate traditional foods 5 times or more per week compared to those that did not. Next slide, please. For socialization, we can see kind of a trend here too. For those that consume traditional foods, you can see that on average, their average time socialized in the past month actually did an upward trend for those who consume traditional foods anywhere from 1 to 5 or more times per week. Socialized in the past month, if they socialize at all, again, an upward trend for those who consume traditional foods at least 1 times per week. So we had some higher percentages compared to those that did not. Next slide, please. For our well-being, for those elders who said that they were a happy person all of the time, there was a higher percentage that consumed traditional foods 5 or more times per week at 31.8%. compared to those who did not at 19.8%. I'm going to skip down to the bottom table, our row, I guess I should say, their quality of life in the past month. Those who said that they had excellent, very good, or good quality of life in the past month. 84.6% had consumed traditional foods 5 or more times per week compared to 77.2% who did not. So again, a positive impact there. Next slide, please. So for this slide, we did a needs assessment survey with Native urban elders. And so these were their word responses in the word cloud for traditional foods. Again, they could write down any traditional foods that they had consumed. So corn, meat, salmon, beans, fry bread, wild rice, vegetables, fish, rice, and soup were some of the top identified foods. Next slide. So here we look at, for the urban population, we just did 2 columns for this one. So we had those who consume traditional foods compared to those that did not consume traditional foods. So we see for average number of chronic conditions, it's just a little bit lower, slightly lower for those who consume traditional foods. Percent with good nutrition status. So those who consume traditional foods had a better health status at 40 points, or I'm sorry, good nutrition status at 40.2% compared to 32.8%. Percents who reported socializing, a higher percentage of elders reported socializing for those who consume traditional foods. Nutritional quality of diet, where they reported excellent, very good, or good, again. Higher percentage under those who consume traditional foods. And then obese or overweight, those who consume traditional foods had lower obesity or overweight percentage. Next slide, please. Affordability of food. I'll just go through a couple of these. The food I bought just didn't last, and I didn't have money to get more. So we see that for those who reported often true or sometimes true, there was about a 44.2% of our elders reported that. I couldn't afford to eat balanced meals. Often true or sometimes true, we see about 50.8% of our elders had reported that being true. Next slide, please. Affordability. So here we looked at 2 of the food security questions, and we compared the urban elders to the tribal elders. So, and please keep in mind that the sample for the urban elders was much smaller than the tribal elders, as you could see in the column. So in the last 12 months, did you ever eat less than you felt you should because there wasn't enough money for food? We see that there's a higher rate, almost twice the percentage of urban elders said that this occurred at 30.6% compared to our tribal elders at 15.3%. In the last 12 months, were you ever hungry but didn't eat because there wasn't enough money for food? Our urban elders said yes at 23.2% compared to our tribal elders at 11.4%. Next slide, please. Okay, that wraps up the data that I wanted to share with you. So overall, just looking at the data and the comparisons, and it just kind of showed that for the most part, our traditional foods and food consumption served as protective factors against some negative health outcomes. We did have some limitations, though, like I mentioned with the fry bread, not exactly a healthy food for us, so probably doesn't have a positive impact on our health. So we didn't pull that out, or any other foods that might not be as healthy. So that's probably why there's some discrepancies in the data. But I just wanted to share that overall with you. This slide here is just some resources that I had found online that has a lot of good information about traditional foods and food sovereignty. So if you're interested in learning more about that, these are some good sites that you can review that information with. Next slide. Next slide. Sorry, that's just my references. And that does it for me. Thank you.
Thank you, Dr. Adamsen. That was so interesting. I am definitely very much looking forward to the question and answer period at the end. I know I took quite a few notes. And then, I'm also excited to introduce our next speaker, Nannette Taho. So Miss Nannette Taho is a program manager for the Intertribal Council of Arizona, Area Agency on Aging, Region 8. In this position, she works with grant and contract operations, provides technical assistance to congregate and home delivered meal programs, and supervises Area Agency on Aging staff. Prior to working at the Intertribal Council of Arizona, Area Agency on Aging, she served for 5 years as the program manager for the Fort McDowell Yavapai Nation's Senior Center. Ms. Taho is a certified dietetic technician registered, and she is a member of the St. Regis Mohawk tribe. All right. Thank you so much, Nannette. I'll let you take it from here.
I'm just getting Nannette connected to her audio.
Oh, perfect. So I had the great pleasure of working alongside Nannette when she was at Fort McDowell Yavapai Nation, and she was such an excellent program manager, and really had some great programs at the senior center. So I'm excited to hear what she has to say today. Oh, okay.
I believe that Nannette is on the phone connection, so I just want to make sure that you have unmuted yourself, Nannette, on the phone side.
I have. Can you hear me?
Yes, we can hear you. Wonderful.
Okay.
Right.
Can everyone hear me?
Yes, you're
Great.
good. I'll let you take it
Okay.
from here.
So thank you, Heidi, for that wonderful introduction. I'm so excited to be here and presenting before you today. Collette, that was a wonderful presentation. Okay, next slide, please. So just a little background. The purpose of the Older Americans Act is to reduce hunger, food insecurity, and malnutrition, promote socialization, and promote the health and well-being of older adults. Next slide, please. So the Older Americans Act is a federal program that supports the health and well-being of older adults through access to nutrition and to nutrition-related disease prevention and health promotion services. The nutrition programs include congregate meals, home-delivered meals, nutrition services incentive program, NSIP for short, and NSIP supplements funding for food. These programs are the heart of the Older Americans Act Title VI grant. And Title VI specifically addresses the unique needs of older adults in tribal communities. Title VI helps us to minimize high rates of chronic conditions, address food deserts and insecurity, and promote socialization opportunities and influence health outcomes. Next slide, please. So screening for nutrition risk, social determinants of health, and malnutrition. How do we go about doing that? Next screen, please, or slide, please. So on our intake form, we use the Determine Your Nutritional Risk assessment form. And if you don't know that, I'll just say that Determine is sort of an acronym for the warning signs for malnutrition. They include disease, eating poorly, tooth loss, economic hardship, reduced social contact, multiple medicines, involuntary weight loss, needs assistance in self-care, and elder years above age 80. So I'm not going to go over each of these questions because of time, but they do capture and depict a good picture of our client's nutritional health. They are weighted, and so when a client says yes to a statement, then we add those yeses and we come up with a nutrition total score. So next slide, please. So these are results from our Title III clients who do this, and we get this information and statistics because it is entered into the Division of Aging and Adult Services reporting system. So this depicts last fiscal year. It runs from July 1st to June 30th. So the key from the Determine Your Nutritional Risk is 0 to 2 score means that the client is at good nutritional risk, 3 to 5 is at moderate, and 6 or more is at high nutritional risk. So we've broken it down between our congregate clients and our home delivered meals clients. And so the 0 to 2 risk score for congregate meals was 28%. 3 to 5 is moderate, so that's 31.7%. And then high nutritional risk is 34.7%. That's out of 1,108 clients. And I do want to add that 62 of our clients did not fill out that Determine Your Nutritional Risk assessment. It's always a challenge to get information from elders. It is ongoing. So for home delivered meals, the good nutritional risk was 14.6%. The moderate nutritional risk was 22.8%, and 62.6% were at high nutritional risk, which is higher than congregate, which you would imagine to be true. And that is 618 clients, and that does include 166 caregivers. And just a few more numbers here for our congregate meals last fiscal year. 14 tribes partake of the congregate meal service, and they served 58,682 meals. And for the home delivered meal service, 8 tribes partake of that service, and they delivered 54,841 meals. And you have to keep in mind that tribes are supported by Title III, Title VI, Social Services Block Grant, and tribal funding to provide those unduplicated nutrition services. So what that means is each grant has different clients. You can't duplicate amongst nutrition services. That is called double dipping, right? Next slide, please. So this is new to us. We just received a new nutrition, food service, and wellness manual from our state unit on aging, and it includes a section 2. So that is going to capture malnutrition screening. So we're asking, the first question is, have you recently lost weight without trying? Yes or no? And if yes, we ask, how much have you lost? And that has a weighted score. And then question number 2, have you been eating poorly because of a decreased appetite? Yes or no? And the yes has a weighted score, and you add them up. And the little key box there, 0 to 1 means you're not at risk for malnutrition, and 2 or more means you are at risk for malnutrition. You're eating poorly and or have had recent weight loss. Section 3 captures food insecurity. So the first question is kind of very much like what Collette was speaking of. We worried whether our food would run out before we got money to buy more. And number 2, the food that we bought just didn't last and we didn't have money to get more. So a response of often true or sometimes true to either question is a positive screen for food insecurity. So we have yet to initiate this. We will be doing it soon as this is entered into the reporting system. So that'll be, and that will help us better serve our clients as well. Next slide, please. So the process for assessing assistance and referrals. So we interview our clients using the short form intake document. It covers demographics, household composition, including number of people in the household, and that is used to determine federal poverty level, whether they are above or below federal poverty level. And then the determine assessment, and then the basic functional assessment, which includes orientation to person, place, time. It also includes sensory, like touch and vision, hearing, smelling. And then it goes on for activities of daily living and instrumental activities of daily living, which are used to also determine home delivered meal eligibility. Then we discuss the service plan with the client, and we make them aware of their client rights and responsibilities. So next, if we do find that they need additional services, we assist them and we refer them to resources. You know, if they need to see a clinical dietitian, we can also set up that appointment for them, or a dentist if we found that they have ill-fitted dentures or dentation issues of any sort, and maybe they do need to see a physician. We also can hook them up with a food bank, or even some of the tribes do have a food distribution program. And then we help with falls prevention. We also do nutrition and health education to promote healthy aging. All sorts of topics are discussed: how to avoid malnutrition, how to nutrition for improved wound healing, gaining muscle mass, consuming nutrient-dense foods. Also, caregiver training is done on all topics of healthy aging. Next slide, please. So, tribal nutrition program challenges. Next slide, please. So we have many challenges. Staff shortages plague us pretty much. There's a lot of turnover in the senior centers, and even more so throughout the pandemic. We still haven't gotten back to par or pre-pandemic times. I think that might be across the board, you know, everywhere. Transportation needs are very, very much needed. I know of maybe 2 tribes that have like a bus system on the reservation. So transportation needs are really important. The increased cost of food and supplies nowadays really makes your grant funding not go as far. So that's challenging. Vendor minimum order requirements for some of our smaller tribes. It's hard to buy from the large companies like Cisco, Shamrock, or whoever. And they do set minimum orders, so they can only order so often, and then they need to have storage room for that. So that's another concern. And so those tribes also have to shop local because they can't buy fresh produce in bulk because it's a waste of money. It's like throwing away money. They don't go through it enough. Some of our tribes, smaller tribes, serve 11 people, 22 people. So they really do have to travel. I know one tribe travels over an hour one way to go shopping for fresh produce every week. So that's a challenge. And also local grocery shopping is a higher cost. And then you have to worry about transporting food at proper temperatures. You want to definitely serve hot food hot and cold food cold. In the desert with the summers over 110, that's very challenging. And then in the winters for the northern tribes, it's challenging to have hot food hot. And then next, the inability to analyze some traditional foods. Some of the nutrition analysis software programs don't have those foods in them. And then some of the tribes do have limited local resources. Not all tribes have access to Indian health services, or then in comes the transportation issue because they're further away. Many tribes are very rural, away from the cities, so it's very challenging. Next slide, please. Oh, wait, hold on. I would like to say that these are pictures of one of the tribes that is down in the canyon, the Havasupai tribe. They are challenged by getting into the canyon and getting supplies there. You can hike for 12 hours. You can get things on a burro, or you can ride the helicopter, which comes with cost. They do put things on slings that they attach to the helicopter. It can hold up to 900 pounds, but it does cost several $100s to get it down there. So it's very challenging. Next slide, please. So what initiatives have we implemented to address the challenges? Next slide, please. So we do technical assistance ongoing all year long. We teach them on reporting Title III and Title VI, how to coordinate your grants. We do education and awareness training on all sorts of topics. The picture, so the next is during the pandemic and with stimulus funding, we were able to purchase 6 tribes with temperature controlled vehicles. So that they can deliver the foods within proper temperatures. In the lower right is a picture of the training that we had when we received those vehicles. So the vendor came out and did training to the drivers. That was really good, really nice. And then all of these other things listed here, we were able to purchase. The generators were really wonderful because in inclement weather, monsoon season, sometimes the power goes out and then you risk losing food in the freezers and refrigerators. So generators were really a good thing that some tribes applied for. Next, I do hold 2 cooks trainings every year, and I cover a lot of different health topics. And at those trainings, we like to provide them cookbooks. And so these are just some of the cookbooks we've provided over the years. The Food for 50 is a food production quantity cookbook, and it has a lot of good things in it, great tables for food production. It can tell you how many half-ounce servings of green beans are in a number 10 can. It is written by a registered dietitian, and it's a lovely cookbook. The New Native Kitchen is awesome. It's from a Navajo chef who actually is the chef in DC, at the Smithsonian American Indian Museum. And he wrote this book from his travels across the nation to all tribes, as well as Pacific Islanders. And it uses traditional ingredients, but using modern cooking technologies. It's a really good cookbook. It also tells you where to find those traditional foods. Education and awareness, I've pretty much covered. Training kits and visuals, we always like to give out visuals for elders. There's a little picture there. There's a wheel that you can spin around, and it has fruits and vegetables on either side, and it will tell you the nutritional content. We also have given different things out, like the nutrition facts label with a magnetized thing so that you can take it to the grocery shop and read those nutrition labels. All sorts of good things that elders really like. Next slide, please. So potential solutions. Next slide. So gardening is a good thing that a lot of our senior centers have started to do. It's just wonderful that they're doing this. They are some traditional foods. They exchange recipes, and there's nothing like watching food grow in front of you from seed to harvest. It's very gratifying, and it's part of our culture. We also are doing multi-generational meal planning, cooking, and storytelling. And a new thing, like I just mentioned, is that we do have a new nutrition, food service, and wellness manual from the state. And we are going to have trainings from their registered dietitian to our program managers, as well as menu planners. And then, of course, the good thing from the FDA guidelines is on the nutrition facts label is that they added the potassium content, vitamin D, and added sugars. And that's great for folks with chronic kidney disease, osteoporosis, diabetes. So that's a good thing. And then community events, our tribes have fun runs and walks and powwows, and some of those include different tournaments, golf, basketball, volleyball, horseshoes, you know, a rodeo, all sorts of things. I do want to point out that in Arizona, our tribes definitely love chair volleyball. Each tribe hosts a tournament, and it's like a circuit. And they're very, very competitive. They will yell at the ref and say that ball was in. But they really enjoy themselves, and it's a good thing for them. Next slide, please. So the role of education and awareness in promoting healthier food choices and lifestyles. Next slide, please. So in addition to all of the previous things that we do, I mentioned the health education and awareness. We also offer evidence-based programs within our area agency on aging. And the first one is A Matter of Balance. It is an 8-week program, and it requires a master trainer, or we have a master trainer on our staff who trains the trainers, and then they in turn hold the classes with their elders. So in those classes, elders learn to view falls as controllable, set goals for increasing activity, make changes to reduce fall risks at home, and safe exercises to increase flexibility, strength, and balance. And you can find more information on that program at mainhealth.org. Another thing, we were awarded additional funding on a new project this year from the state. It's the Home Modification Project, and that is to address falls prevention and assist those with disabilities. So we're able to purchase grab bars, widened doorways for wheelchair access, outdoor ramps to the front door, ADA compliant toilets, and things of that nature. So we're really excited about that. And then the next evidence-based programs that we offer are the Chronic Disease Self-Management Program and the Diabetes Self-Management Program. Those are 6 weeks programs where clients learn to manage chronic conditions. They learn safe exercises. They learn about healthy eating, medication management, reading those nutrition facts labels, decision-making, problem-solving, and action planning. And for the diabetes self-management, more specifically, they learn about proper foot care and monitoring their blood sugar. And you can find more information on those programs at selfmanagementresource.com. Next slide, please. So that's it. Thank you. I know I went really fast. I was keeping time in mind, hoping for questions. This is my contact information, and I will hand it back to Heidi. Thank you.
Yeah, thank you, Nannette. That was so interesting. My gosh, you both are are doing a lot of work. I'm curious when you find time to sleep. But please, for all the audience members, please, go ahead and put your questions in the Q&A box. And then I have a few questions myself. So Nannette, don't don't go away. You're up first for my question. Um, I'm curious to know, what are some areas or topics that you would like to introduce to the ITCA member tribes?
Oh, that's great. Um, I'm really looking forward to working more with grandparents raising grandchildren. I really want to reach out to them and discuss things that they need to know. Talk about child food allergies, healthy snacks, food safety and cooking, and even cooking for teens that are potentially going to go off to college. They need to learn how to cook. There aren't very many schools anymore that have home economics like we used to. I'm dating myself now, but I had home economics when I was growing up. I think those have almost gone away now. I also want to reach out and do a multi-generational project. I want to do some traditional food cooking, and I want it to have some storytelling about those foods. And my other dream, I'm hoping will happen this year, is to have a cook's training and make it a cooking competition where they cook a traditional dish, but they modernize it a bit. And so I'm looking forward to that. Yeah, I think that's about it. Thank you.
Yeah, thank you. That all sounds really exciting. And my next question is for Dr. Adamsen. So, Dr. Adamsen, I'm wondering, what are some of the things that really have stood out to you as you've analyzed your data? Both for the urban elders and then those on reservations. Are there like certain pieces of information that just really stick in your mind?
Well, I think one thing there's a couple things. So when we were looking at the urban elders, you think like, oh, they're in urban areas, so they have a lot of access to support and resources. But it was a little bit surprising, but not as, that they actually showed to have more needs than like our tribal elders. And I think sometimes, like being, even for myself, like being in a tribal community growing up and living there, and then coming to like a more urban area, you have more support sometimes, like with like family and just community in our tribes. So I feel like maybe that's why the data was showing that there was more need for urban Native elders, because when they're in the urban areas, yes, there might be that nutrition program or aging program for elders to go to, but if they don't know about it, it's so large and they're not in that community to make them aware or even to transport them there, they're not getting those services. So looking at that data was really eye-opening, because now it's like, okay, now we got to take this data for urban Native elders and try to advocate to get funding and resources to try to fill those gaps and those services needed for them too. I think for both our tribal elders and our urban elders, it's like, like what Nannette talked about, like our grandparents, caring for grandchildren or raising grandchildren. There's a high percentage compared to the rest of the non-Native elder population that are caring for their grandchildren, are raising them. And one thing that really stood out is when we looked at some of the other variables like income, it was like really low. Like I think for the tribal elders, it was like there was a high percentage, almost a fifth, that were under like 5,000 a year for income. And then the other one, I think for urbans, was like under 10. And it's like, gosh, we have our urban elders who are raised and tribal elders raising their grandchildren, and they're living off of this very small income. Like we need to get more resources and supports for them. So those are some things that stood out. There's a lot of other things that stood out, but I guess, yeah, I don't want to take up all the time. I'm data nerding out, so I apologize.
No, I appreciate it. Yeah, I think you brought up a really good point, and thinking about also the grandparents raising grandchildren, because, not only is it Native American Heritage Month, it's also, Caregiver Month, and grandparents raising grandchildren, something you both brought up, are, so important to, the future generations. So I think, I'm continuing with you, Dr. Adamsen. I have a follow-up question is, what are some ways that people can use your data to help advocate or to help strengthen programs for the elders?
Well, I think, of course, just looking at your highest needs, because, sometimes, like I remember Dr. Hudgens, Chrissy talked about this at the Title VI conference this past year, like, this data gives you evidence, and so like when Cynthia was talking about, back in the day, we were just like, oh, these are our needs, but they're like, okay, well, we need to see numbers. So, that's a big thing, is just having those numbers, having that evidence to show this need. So like you're showing your legislators, like maybe at the state or even federal levels, like, okay, we have the evidence now, here's like the reliable data, the accurate data, this is what we need. So just utilizing the data in that way, helping to strengthen your grant applications, being able to report those numbers into those grant applications, planning within your community, even going to like your tribal council to be like, hey, here's some needs for our elders, because, like Title VI and Title III, those are more like, like kind of like supplemental programs. We all know that there's not enough funding there to support all the needs of our elders and our communities for nutrition support and caregiving services. So, having to supplement that with like even resources from your tribal, your tribal council, your tribal communities for the funding they have. We worked with the Title VI programs in Hawaii. We actually helped create some of their specific data, like their data booklet, a data booklet that they were actually able to bring to their legislators to show their needs too. So just using it for advocacy too, and trying to get that policy change, especially with the Older Americans Act reauthorization coming up. Data is really important for that as well. So
yes, good good point. There's definitely a lot that can be done. And then Nannette, I'll bring it to you for my last question. So, during the presentation, you definitely brought up, a lot of resources and a lot of really good ideas for cooks training. I know I added a couple cookbooks to my cart already as you were talking about them. And I'm curious, do you have any quick recommendations for new cooks that are working in tribal communities?
I do. A lot of cooks come to us sometimes from the casinos, and that's not healthy food. So they need to learn what the elder needs are. They need to know what the nutrition requirements are for healthy aging. So I do a one-on-one usually with a new cook, and we cover all those topics: renal disease, diabetes, soft foods, all sorts of things. So yeah, I recommend the following. So I always tell them to read the Nutrition, Food Service, and Wellness Manual for the meal pattern, and food lists that contain needed nutrients that promote healthy aging. We always want them to gather input from their elders, and then connect with the tribal health facility, whether they have access to a registered dietitian through the Indian Health Services or myself. And then we always want them to incorporate those traditional foods. That's part of the Older Americans Act requirements, and they love it, of course. So they need to learn how to cook those foods too. So elders are happy to help too. And those elders may need to compromise sometimes, like Collette was saying, the fry bread isn't that healthy. So we always recommend to make it much smaller. You know, some of the fry breads are the size of a plate, which for elders, we don't want it to be that. You know, we ask them to make them much smaller and not serve them as often, you know, just occasionally, which I recommend quarterly. We try to get away with that. Um, and then, and when they do cook, to try and incorporate some whole wheat flour, at least a portion of it, sneak it in, give them some fiber. So different things like that. You know, we talk about cooking methods to decrease fats, less sodium, rinse and drain your canned vegetables, you know, all those things of that sort, and to try to keep natural sweeteners in desserts, like using the berries and that sort of thing. So
Excellent. Thank you. Thanks for all that advice. And I appreciate you, Nannette, and you, Dr. Adamsen, for coming and participating in today's webinar and sharing all this wonderful information. All right.
Well,
thank
thanks for
you.
having us.
Yeah, thank you. All right, Georgia, I'll turn it over to you.
Thanks. I'll just wrap it up and thank everyone again, all the speakers, and also Abbott for sponsoring today, and Defeat Malnutrition Today for collaborating on the topic and all the programming. I learned a lot as well and took lots of notes too. So thank you to everybody. I did put the contact information on, but I can pop that up again just in case anybody needs it. Oops. I'll get that on for you guys. And that way, if you need to contact any of the speakers, you can. And as I mentioned, I will be sending the recording out in the next 24 hours. So if you have any follow-up questions, feel free to ask the speakers or myself, and stay tuned for the recording. So thank you and have a great rest of your day.
Thank you.
Thank you.